Dear ladies and gentlemen, thank you for the word and also for the option of participation in this meeting. My name is Bela Mrinakova. I work as medical oncologist in, I don't think you can see, okay, in St. Elizabeth Cancer Institute and also Comenius University in Bratislava, Slovakia. Hopefully I won't disappoint the organizers of the Ceiling program, which was very nice to participate in. So here are my conflict of interest. I would like to present the last molecule which made it to this top 3 of the year in this meeting, then that is Cabozantinib. Cabozantinib was first registered as an orphan drug in 2010. It's a small molecule, and you can see that it has liver metabolism. It's a peroral drug with kind of very strong binding to plasma proteins, which has a half-time of elimination about 5 days. And actually it has 2 formulations for peroral use. One is in capsules and the other one is in tablets. Interestingly, these 2 formulations are not interchangeable, so the only approved registration of the capsule formulation is for medullary thyroid cancer, and all the others are using the tablet formulations. So here we can see the mechanism of action of Cabozantinib. It is a multi-targeting agent, a small molecule which has a nice penetration even to the CNS, which was seen in multiple studies. Its main targets are MET and AXL, which are included in the proliferation cascades and even metastatic potentials of cancer cells. And it also blocks the VEGFR, which is included in the newer vessels formation and angiogenesis in tumors. Interestingly, these are not the only targets of this drug, and we can see that this drug has multiple forms of action even in bone in microenvironment, which is very interesting because we've seen this effect in the patient with poor prognosis and especially progression in the bones in various diagnoses, especially in renal cell cancer. It affects also the bone turnover, which we can see in the decrease of the CTX and the increase in parathyroid hormone-like structures and even parathormone. And this comes very early after the onset of the treatment. We know that bones might be a nice reservoir of various proliferating factors as well as cytokines. So this might be a nice way to inhibit the cancer cell progression and even the epithelial mesenchymal transition of the cells. Cabozantinib has also immunomodulating properties. And we can see it in the tumors which have VEGF overexpression, that those bad guys Professor Zielinski was mentioning, which are the regulating the lymphocytes, are really increasing in the tumors that have overexpression of VEGF, while blocking it might be a nice effect for immunomodulating of the response to this treatment as well. And we can see that the VEGF overexpressing tumors have also decreased antigen presenting properties. So Cabozantinib, due to its immunomodulating properties, might be a very nice drug used in combinations with various immunomodulating drugs, especially immunotherapy. So there are currently 3 approved indications of Cabozantinib. The first one we are going to discuss is the renal cell cancer. The first study that made approval in this indication was the METEOR study, which tested Cabozantinib after the progression of on VEGF tyrosine kinase inhibitors. There was a second or consecutive line of treatment, and it made a comparison with the mTOR inhibitor in everolimus. So in this phase 3 trial, we could see gain in primary endpoint, which was progression-free survival, and also there was a significant difference in the overall survival. So this study led to the approval in the second-line treatment after standard anti-VEGF treatment. Here in this study, I will also present a little about safety of this drug. So here you can see that the safety is comparable to other targeted treatments. This is the everolimus. Almost all of the patients suffered at least a mild stages of some toxicities. Most of those were really likely just mild diarrhea or fatigue. But in cabozantinib, we can also see some severe toxicities, such as palmar-plantar dysesthesia, or hypertensive crisis, or even fistulae formation, hemorrhagia, or thromboembolic complications. So the toxicity of the drug is manageable, even if the patients approximately half of the patient experiences grade 3 toxicity. This is manageable after dose reductions of this compound. So after these results of the METEOR trial, the drug moved to the first line of the treatment with the Cabozan study, which was the phase 3 trial that proved prolongation of the PFS and also increased objective response comparing to sunitinib in the treatment of kidney cancer. Now we know that immunotherapy gained the standard of the treatment in this diagnosis, and it was also a response in the phase 3 trial CheckMate 9ER, where the combination of immunotherapy, nivolumab and cabozantinib was tested against the sunitinib treatment. And in this clinical trial, again, the combination with cabozantinib gained prolongation in the PFS, and we've also seen a tendency to prolonged overall survival, but the data were not still mature and will be published early. So after this, the treatment with cabozantinib and also nivolumab became a standard of treatment, one of the standards of the treatments and the recommendations in the treatment of the kidney cancer in the first line, as well as in the second line of the patient, or for the patients in monotherapy who are not I would say, in good status to undergo the immunotherapy treatment. So here you can see that the combination is also indicated in the good risk, in the good prognostic group of the patient, while the monotherapy with cabozantinib was tested in the intermediate and poor prognosis. The second indication of cabozantinib is in hepatocellular cancer. So here, the registrational study was the phase 3 study Celestial, which tested the second or consecutive lines of the treatment, where it compared cabozantinib to the placebo. And the treatment with cabozantinib resulted in the prolongation of the progression-free survival, 5.2 versus 1.9 months. So this was a registrational study as well, and led to approval of cabozantinib in the second line. And while this was really tested, the consecutive lines of the treatment, currently it's the only drug that which should use evidence-based in the third line of the treatment of the hepatocellular cancer. Interestingly, there are also being tested combinations with the immunotherapy in hepatocellular cancer. This is the COSMIC-312 trial, and as well there have been tested the triplets of the combination in the renal cell cancer with ipilimumab and nivolumab as well. The last indication of cabozantinib is in thyroid cancer. We have these two formulations of the drug. One, the capsule formulation, is used for medullary cancer. This was after the registrational trial exam. This was a phase 3 trial that tested cabozantinib in the Cometriq capsule formation against placebo. And we've seen a very nice results, substantial prolongation of the PFS, 11.2 versus 4 months, so really a substantial gain. We didn't see that good results in overall survival, but this led to the registration of the drug in the refractory medullary cancer after the TKUs. We have another indication, this time for the tablet formulation of the drug, and this is really the breakthrough of the year and why the cabozantinib made it to this session probably. And this is in the iodine refractory papillary and follicular cancer after the treatment of levantinib or sorafenib, which was for long an unmet criteria in the medical oncology. And this patient with bad prognosis, we didn't have many options to give them. So here we can see that the cabozantinib was compared to the placebo, and again very alike to the medullary cancer. It gained a substantial prolongation in the PFS, 11 months against 1.9. So again, we don't see this overlap in the overall survival, but it made a registration in this indication for radio iodine refractory patients. As we look at the analysis based on the previous treatment of the patient, we can see that cabozantinib treatment is very active after sorafenib and also levantinib, and it doesn't really matter. Both of the curves are separating nicely after various treatment arms. So I looked at the ongoing trials of cabozantinib, and I was really surprised that there are 132 ongoing trials with this molecule, which made it a nice interest drug in the oncology currently, and it's being tested across various diagnoses. And I also choose these because these are the trials we are awaiting the results in the near future. And here you can see most of those are the combinations with immunotherapy, such as cabozantinib with atezolizumab in hepatocellular cancer, or the triplet combination in renal cancer, but also in non-small cell lung cancer, where the cabozantinib is tested with atezolizumab. So thank you for your attention, and I'm awaiting questions. Hopefully I can.
Thank you very much. Also an excellent presentation. We have here the same situation as with levantinib, that is active in the same indications: renal cancer, thyroid cancer, liver cancer. So this is, I think, these are the tumors where this dirty drug work really well. And you also pointed out that the future for these drugs is the combination with IOs. So that's pretty interesting. I don't think that it will be very active in lung cancer because we have these negative trials in lung cancer in several indications. So we'll see whether it works here. I have my doubts, but I'm pretty sure that in the indication you pointed out, there will be progress with these combinations. Thank you.
Really a breakthrough, as Dr. Mrinakova pointed out, because there we really don't have anything. And this was a major, major step forward. But another aspect is renal cancer, what you asked before. So it's another compound which we can again use, and we really don't know what to prefer. In an indication which is not that frequent. I mean, we have in Austria, we have, I believe, 440 cases per year of renal cancer. So this is, as Tanya said, a busy area.
It was also nice to read the comparison between the levantinib study and the cabozantinib study. And what I can maybe point out was the selection of the patient, which was a little bit different. So much more patients were after nephrectomy in the trial with levantinib and had better prognosis. So.
Maybe a naive question from a gynecologist, but for thyroid cancer, there was this huge benefit in progression-free survival and no difference in overall survival in a rather late stage of the disease where you would like estimate or guess that if you have a huge difference in PFS, you would also see it in OS? Is there any explanation for that?
Maybe also the statistics of the trial were set quite sharply because the arm, experimental arm, they had also a very nice response rate, about 17% versus 0%, but it didn't gain statistical significance as well. So.
Maybe the answer is, I don't know, I just think that I have seen that there was an arrow, so maybe there was possible to switch after the progression on placebo to the active drug, and therefore we don't see differences in OS. I don't know, but I have seen an arrow there, so maybe.
Could be, I'm not really sure about this.
Another aspect which you never know with these drugs is what you induce. I mean, you could reinduce, for instance, iodine dependence, etc. So what we have to be aware that, again, I think Martin could show this very nicely probably in liquid biopsies. But what we have here is that we do have selections where people may become again sensitive to a certain compound. So this is something which is quite interesting. When you look at CDK4/6 inhibitors, this is a good example probably.
For ALK-positive non-small cell lung cancer, there are data showing that patients already treated with crizotinib, larotrectinib, they were sensitive to crizotinib again. Yeah, it was published in New England Journal of Medicine by Dr. Shaw. Yeah. So we never know what happens with these mutations, alterations during the course of disease. Yeah. So liquid biopsy will be very interesting thing in future, I think, for tailor treatment in metastatic disease. For primary diagnosis, probably we will still rely on biopsy, tissue biopsy. But for tailoring the treatment and modifying liquid biopsy probably will be the very good tool to use. I don't know what is your opinion.
Yeah, I completely agree. It's complicated because it's not so easy. It's easily said, do liquid biopsy and find these aberrations. It's challenging because you have very low amounts of material and you need the right methods. And it's interesting, I agree, but it's a lot of work to do.